Hello, everyone. Good evening. We're just going to give folks a few minutes to get into the webinar. Thank you for joining us. Thank you again for joining us. We're just waiting a few minutes for folks to enter the webinar. And we'll be starting in just a few moments. Good evening again. Thank you so much for joining us tonight. We're going to get started in just a few minutes, giving folks a chance to get in. All right, well, I think that we'll get started. Good evening again and welcome. My name is Dara Fruchter, Project Manager, Substance Exposed Infants and Maternal Use Prevention Coordination at the Maine Center for Disease Control and Prevention. Tonight, we're celebrating the opening of our two-day Maternal and Child Health and Substance Exposed Infant Virtual Conference, which begins at 8:30 tomorrow morning. Our conversation this evening revolves around a book published a little over a year ago, Understanding Addiction, No Science, No Stigma. It's an honor to welcome the authors, Dr. Jason Hunt and Dr. Charles Smith, and guests Sarah Squirrell and Abby Fruchtey. Before I begin introductions, I want to say a few words about why I chose to highlight this book on the eve of our two-day conference. We know that when myths overshadow facts about substance use disorder, stigma contributes to unnecessary barriers for those seeking needed care, support, and pathways to recovery, barriers which may be life-threatening. This little book is divided into 13 chapters with only 120 pages, but it speaks volumes. Written using plain, straightforward language, it's easy for the reader to access the foundation of information Dr. Hunt and Dr. Smith provide about the science underlying the disease of addiction, the role of the brain, identifying risk factors as a way to prevent substance use early in the lifespan, screening and intervention, treatment, long-term recovery, and the idea of moving from the traditional long-term therapeutic approach in treating substance use disorder to a multifaceted model to help individuals sustain recovery. They have devoted an entire chapter to pregnancy, acknowledging that pregnant persons with substance use disorder are likely one of the most highly stigmatized populations within our communities. Dr. Hunt and Dr. Smith wrap the gift of their personal stories of substance use disorder and recovery around the book's content, gently offering readers the opportunity to understand the science of addiction within the context of what they have experienced themselves. Before I begin introductions, as an attendee tonight, you will receive a free copy of Understanding Addiction, No Science, No Stigma in the mail. I want to thank Marianne Haricall, Director of Maternal and Child Health at the Maine Center for Disease Control and Prevention, for supporting the purchase of these books. It's now my pleasure to introduce our guests. Dr. Jason Hunt is an assistant professor of addiction medicine at the University of Florida College of Medicine, joining the faculty after completing a fellowship in addiction medicine. He now practices addiction medicine at the UF Health Florida Recovery Center. His responsibilities include evaluating impaired safety-sensitive professionals and caring for patients in the alcohol and drug detoxification unit at UF Health Psychiatric Hospital. Before becoming an addiction medicine physician, Dr. Hunt worked as an advanced drug and alcohol counselor in Alabama and Tampa, Florida. Dr. Hunt earned his medical degree from the University of Illinois and completed a residency at the University of Louisville. He specializes in opioid use disorders during pregnancy, substance use disorders, the evaluation and management of dual diagnosis substance use disorders, and substance-related impairment. Dr. Charles Smith is an addictionologist in South Florida, where he provides detox, residential, and outpatient management of addictive diseases. He graduated from Marshall University and West Virginia's School of Osteopathic Medicine. Dr. Smith has also completed an addiction medicine fellowship at the University of Florida. Sarah Squirrell is the acting director of the Office of Behavioral Health. Previously, she has worked in the Commissioner's Office on the development of a plan for increasing school-based health services in Maine, with an emphasis on behavioral health services. Given the toll COVID-19 has taken on children and youth in Maine, Sarah has worked with the Department of Education on increasing access to mental health services in schools this year. Sarah also previously served as the Commissioner of Mental Health for the state of Vermont. She created a strategic plan for the state's mental health system, oversaw 2 state-run facilities, and developed and implemented behavioral health initiatives to respond to the COVID-19 pandemic. Sarah has led various nonprofits in early childhood education and mental health. She has a Master's of Science degree in community mental health and clinical counseling. And our conversation facilitator, Abby Fruchtey, is the Substance Use Response Coordinator for the Community Caring Collaborative in Machias, Maine. Her work focuses on program development, organizational training and technical assistance, and collaborative efforts to address substance use challenges in Washington County. She's a licensed master in social work, licensed alcohol and drug counselor, and certified clinical supervisor. Abby may look familiar to some of you. At last year's conference, we shared a short film featuring Abby and her husband, Brian, sharing their partner recovery story. I want to thank all of you again for joining us tonight. Abby, passing to you to begin our conversation. Thank you.
Wonderful. Thank you so very much, Dara. And thank you for all of you that have attended tonight, the more than 100 that have registered, and those of you that have made the attendance and made the time to join us tonight for this wonderful conversation. It truly shows your commitment to advancing the work of substance use informed practices to support our community members across the state. Truly, I want to thank each and every one of you for the work that you do daily and for really coming together over the course of the next few days for this conference to build on the knowledge and skills that you have to move this work forward. I also want to take the opportunity to say Happy National Recovery Month. For those of you that may not be aware, September is National Recovery Month, which is an opportunity for us to celebrate all the work that's occurring across the state, as well as to celebrate the individuals and families that are just committing to their recovery and to the efforts that they put in. Also recognizing that Recovery Month is about taking action, and that's what we're doing here tonight and over the course of the next 2 days. As Dara had shared, I live and work in Washington County, and my role has led me to work with a number of partners across sectors and populations, including workforce, behavioral health, education, justice, child and family, and our tribal communities, all to address some of our biggest challenges and most vulnerable community members in light of the impacts of substance use disorder. I am so grateful to be a part of this work. You'll hear a theme throughout tonight's conversation, and that theme is about relationships and connectedness. We'll also really identify that one of the biggest factors in impacting relationships and connectedness with the community members that we're supporting is substance use related stigma. I'm so excited to move into the conversation with Dr. Joseph Hunt and Dr. Charles Smith, authors of Understanding Addiction, No Science, No Stigma. Over the years, I've read a number of substance use and recovery related books, literature, and this book was really just a beautiful combination of sharing real life lived experience, the lived experience of two physicians that have also been directly affected by their own substance use disorder, which in itself breaks down societal stigma around the societal norms of who may be impacted by substance use disorder. And it ties in nicely with understanding the brain science around substance use disorder. Reading this book also taught me new ways to move into conversation with others that maybe haven't been exposed to understanding the science behind addiction, or those that may still see substance use disorder as a moral failing. So it was a beautiful combination of personal stories and the science and understanding. But I know everyone's so excited to hear from Dr. Smith and Dr. Hunt. So without any further ado, I would welcome you to answer this first question to really kick us off, to share with the audience what led to your decision to write this book.
Well, I'll let Dr. Smith start this off. This was definitely his brainchild, and he'd come up with the idea that he wanted to write a book probably 10, 12 years ago. And then we started on it several years ago by taking notes and putting things in my phone and just different things. I always had it in the background of my mind to always do this book, but without Dr. Smith's or Chuck's persistence to keep me in line, this never would have been written. So I want to let Dr. Smith kind of start off.
Well, the main impetus for this book, as Jason said, started when we were in treatment ourselves. We always enjoyed hearing either other specialists or national speakers or even our own therapists who told us the disease, what they called then the disease theory or the disease model. And I don't think Jason or myself, either one, came to treatment believing it was a disease 13 years ago. But after hearing that, we understood the impact it was. We knew from medicine it was very important for patient compliance, for patients to understand as at least a cursory pathophysiology of the disease. You get much more compliance. I always did that with my diabetic patients, diabetic teaching. I wanted them to understand the hows and the whys of our treatment plan we put forward to them. So as we did alcohol and drug counseling on our path back to medicine, we started teaching peer support groups. And we always got excellent feedback from the peer support groups. Then when we started practicing ourselves, both Jason and myself, we always got good feedbacks from patient groups, from family conferences. And many times after we would do a presentation, they'd say, "Is this in a book anywhere? I really want to read this. This is a lot of material for 1 hour." So that prompted us about 2 years ago to really, I guess it was 3 years ago now, to really start digging in, try to put something together that was readable. Then, kind of happenstance, we made it a clinical case presentation. I don't know that it started out we were going to do that, but we certainly share our own experiences with our patients through self-disclosure. So as we had a few chapters bounced around among peers, they said, "Yeah, we like that. We like that clinical case presentation model." So that's actually how the book came about and how I use it today as a patient education tool. And it was so well accepted by our patients is why we decided to make it available to the public.
Wonderful. Thank you so much, Dr. Smith. Dr. Hunt?
Yeah, I have to agree with Chuck. I didn't come in believing addiction was a disease. And when Chuck and I trained, Chuck's a little older than me. I won't reveal his age, but there was no real much addiction taught in medical school. And unfortunately, that's almost true all the way up to today. It's gotten better over the last couple of years. The opiate epidemic has definitely sparked that. But I've had I did 5 interviews for fellows for our addiction medicine fellowship last Wednesday, all from internal medicine, family practice, psychiatry, and they were all young and just out of residency, and none of them had addiction treatment in medical school up to this day. Now, here at the University of Florida, we've been training them since 1998. So there was not a lot out there, and that's kind of what led to probably what's happened in the addiction environment. There wasn't a lot of science to back it up. And it took that for me to believe it, even though when, like Dr. Smith said, when we were in treatment, there still was not a lot on it. And what was out there was almost too technical. And it took me to do kind of some research on my own, search out some of the more prominent speakers and educators on addiction, which most of them were in recovery. And I had to have the facts to believe it. I wanted to believe it, but I needed to know that I was believing something that was backed up by science. It definitely made me feel better about my condition, which reduced the shame and the guilt. But I really wanted it to be true. I wanted it to be science-based. And after Chuck and I really researched the prominent figures teaching the science-based medical model, it really did help. And that's kind of, we wanted to explain it in an easier form where patients and families could get it, with versus like what we had to do, journals and thick textbooks that are boring to read. And so that's kind of what sparked it.
Great. Thank you so much, Dr. Hunt. We look forward to diving in deeper to that too, as we go on in the conversation. Sarah, we'd love to hear your reflections after reading the book and some thoughts that you had.
Great. Thank you, Abby. Good evening, everyone. Great to see you all. So wonderful to be here with Dr. Smith and Dr. Hunt. And first, as everyone noted, September is Recovery Month, a great month to celebrate and to have the voices of those in recovery be heard. And just as both Dara and Abby have noted, I think the greatest gift that Drs. Hunt and Dr. Smith gave us in this book was their stories, the vulnerability, I guess the truth of their experience, the angst and pain that they endured and that they shared with us. I also appreciated and really reflected on how they place substance use squarely and definitively within the context of disease, so that it can be understood truly as an illness. And as they noted in their book, as a society, we remain in a state of denial about the true nature of addiction. And I would also note that it is a devastating illness. I lost a very close immediate family member to substance use. They lost everything to their disease. And even as a family member, I felt deep shame around that loss. My family and I essentially hid away from our pain. We mourned in isolation and felt the intense guilt of not being able to help them. And so I want to thank Dr. Smith and Dr. Hunt for giving a voice to that shame and guilt and the pervasive and powerful effects of stigma. I think we have to continue to move away from any notion of people as problems to be solved and focus on the power of resiliency and recovery. Even today, I think our society does identify need as a deficiency. And as human beings, we should never be defined by our illness, but it should be our strength and our courage that define us. I also reflected in the book how Dr. Smith and Dr. Hunt continue to encourage us not to forget about our young people. And we need to continue to go upstream. They notice how at risk our adolescent populations are. I mean, the brain science is clear on this, given that their brains don't fully develop until the ages of 23 or 24. And they highlighted the risk factors around adverse childhood experiences. Early developmental trauma literally rewires the brain and makes our young people susceptible to increasing anxiety and depression that can lead to substance use. I think the bottom line is we have an opportunity here in Maine to earlier intervene. And the bottom line is the earlier we intervene, the better the outcomes. And on top of that, I think we have to remember that our young people are our future. They're our future leaders. And I think they're our greatest ambassadors for tolerance and breaking down stigma and for promoting acceptance. So we have to continue to keep them squarely in the center of our work related to prevention and substance use here in Maine. And I'm just delighted to be here tonight. So thank you.
Wonderful. Thank you so much, Sarah. And that was so well said, and really look forward to hearing more about the work that's happening across Maine. I know you'll be sharing that with us a little bit later on. I just want to share one of my reflections of the book, really right from the forward, right in the very beginning, written by Dr. Teitelbaum. My attention was absolutely fixed by this very first paragraph. And he wrote, "It's an ugly illness. Unlike most other illnesses, substance use disorder is characterized predominantly by behavior. We see it most clearly in people who have harmed themselves or others, who have lost everything to their disease, who have been unable to stop the binges, who have seemingly refused to change their ways. We see it, in other words, by its outward effects. This is where the stigma comes from. Dr. Hunt, we look forward to hearing your comments around understanding the science as you walk us through these next few slides.
And all right, perfect.
Wonderful, thank you. And Dr. Hunt, we look forward to having you walk us through these slides and really looking forward to hearing why it's necessary that we understand the science of substance use disorder and launch our work from that disease model to reduce stigma, along with improving the impact of prevention, intervention, treatment, and harm reduction. So we look forward to hearing that from you.
Okay, yeah, can we go to the beginning? That's the last slide. Going on. Perfect.
Wonderful, perfect, thank you.
Okay, you can go to the next one. So basically, when we discuss addiction, it's impossible to not talk about stigma. You know, the stigma of addiction and stereotypes of the people that suffer with this disease impact our policy decisions and the way we have shaped treatment for the last 100 years. And understanding that addiction actually impairs the brain, changes the brain, changes the structure of the brain, may reduce stigma. And most importantly, knowing that a biological basis of this chronic disease is a strong argument for parity, that is treating and funding for treatment that is equal to other biologic diseases. And I want to make it clear through this talk, you know, disease is an ugly illness. It's not pretty at all. And it comes with some pretty significant bad behavior. But I want to make it clear that it's not an excuse for those behaviors, but more of an understanding of how that can happen. So what is addiction? We talk about addiction, and is it a moral failing? Is it a choice? Is it a weakness? Is it a physiologic dependence? Is it a learning disorder? A lot of neuropsychologists out there will pin it on a learning disorder. That does play a part. Is it a lack of willpower? Is it an amoral condition, or is it that age-old argument that addiction is a sin? Well, decades of neuroscience have told us that addiction is a chronic brain disease that changes the brain. And in fact, some of these changes may have happened or occurred before the first drink or experimentation of drug use in early childhood. As Abby said, trauma and severe or adverse child experiences can really change the brain, kind of like severe addiction does. So it kind of sets that child up for addiction if they're exposed to a drug or alcohol at an early age while the brain's developing. And the brain develops up until about 25 years old. So the main things that characterize addiction are, you know, loss of control, compulsive behavior, craving, continued use despite negative consequences. That's the one that I really harp on and look for. And then it actually causes persistent changes in the brain's structure and function. Next slide. And when we talk about disease or mention that addiction is a disease, a lot of times we're met with eye rolling, or you're making excuses for their bad behavior. And, you know, critics of the addiction model, the addiction concept, which I'll admit is not a concept anymore. The science is there to pretty much prove that it fits. It's a disease like any other. But critics don't mind calling it an illness, an affliction, sickness, a malady, abnormal condition, problem, disorder. I don't know why we have to complicate things. All those words are synonymous with addiction or with disease. They all mean disease, but there's something about the D word or disease that causes a lot of problem. I think maybe the stigma behind, you know, if they don't want to classify addiction as a disease because they want to give some responsibility to the person. Well, you can still give responsibility to the person in addiction, even if it's a disease, just like with diabetes, heart disease. Voluntary choice adds to the acquiring addiction or those other chronic diseases. But if you were to look up disease in any dictionary, medical textbook, Wikipedia, you would basically find the same definition. And it would say something like a disease is any condition which results in the change in structure or function in an organ or organ system that leads to symptoms. So quite simply, it's an organ or organ system that is not normal. There's changes to its structure and function that leads to reproducible symptoms. Every disease fits this concept or this model. Diabetes, for example, the organ is the pancreas. The defect is an impairment in the beta cells, which leads to a change in the insulin receptor, which causes insulin resistance, that causes high blood sugar, that leads to all the symptoms anybody with diabetes knows. Now, granted, diabetes type 2 is also a voluntary condition. We know exactly how to prevent it, but voluntary lifestyle can lead to type 2 diabetes. But we've never heard type 2 diabetes called a choice, even though there is a choice in their lifestyle that can lead to it. Hypertension, the organ's the heart or the circulatory system, the defects in the renin-angiotensin system, and it leads to the symptoms of high blood pressure. We know that voluntary choice leads to hypertension and high blood pressure as well, but we still don't refer to it as a choice. It's still looked at as a disease. Now, take, for example, addiction. The organ or organ system is the brain, particularly the cortex and the limbic system or the midbrain. We know all there is to know about the pancreas. It's a very simple organ. The brain, we're still learning a lot about. Now, the defect in addiction is also a stress-induced dysregulation or dysfunction of the dopamine reward system. Where in hypertension, it's a stress-induced dysregulation of the angiotensin-renin system, and in diabetes, it's basically a defect in the insulin system or the insulin resistance. Just like in addiction, it's dopamine resistance. So you can see that where I'm going with this. The similarities are all there. Now, at the same time, to say that substance use is all biology is oversimplification. Definitely environment and voluntary actions do play a part in it. Now, the symptoms in addiction are laid out in the DSM-5, and most of them are looked at as behaviors, but there's 11 criteria that are reproducible and lay out what addiction is. Just a quick look at the next slide, which looks at imaging of an impaired organ or a diseased organ. On the bottom, you see heart disease. You see by this imaging study, there's an impairment in the structure and function of this heart. That's what the nice, pretty colors show. It shows that this heart on the left is fully intact and is able and has full function. This person could go out and run a 5K. This heart is doing exactly what it's supposed to do. On the right, you see heart failure or heart disease. This heart is definitely impaired. It's not normal. On the top, you see on the left, a perfectly normal brain, perfectly intact with good structure and function. But on the right, you see a diseased brain. This brain, specifically in the lateral prefrontal cortex, which we talk a lot about in the book, is our kind of executive decision maker. Person with this brain is not going to be able to make the decisions the other one has. It's impaired thinking, decision making, knowing right from wrong. Now, people have no problem looking at the bottom right heart and calling that heart disease, but a lot of people have a hard time looking at the top and calling that brain disease. I happen to throw the other side in just because addiction impairs and affects the same areas where mother loves her child and child loves mom back. That area can actually disrupted, get dysregulated, and actually not function. So it shows that even a mother can lose the ability to care for her child, and it's not a choice, it's actually biology, because that same area gets impaired. We talk more about that in the book as well. I can talk about that all day. We just don't have time today. Dr. Smith, before I move on to just a few quick things, do you have anything to say on what we talked about?
No, I use all of these examples daily with patients, certainly related to diabetes, to hypertension. And as you mentioned, the risk factors such as adverse childhood experience. As I'm doing intakes on patients, I'm constantly going through their risk factors with them. And I think by the end of the first session, they understand more than ever why they're there. How come they're in rehab in the first place?
Thank you, Dr. Hunt. As you move into the next slide, this sets us up because we recognize that there's a lot of myths about substance use disorder, what it is and what it isn't. You talked about that very early on in the slides. Looking forward to hearing you speak on the importance of translating the science, what you just shared with us, into a way that's accessible, really for everyone to understand, and why that's so important. We know that's a fundamental part of your book.
Well, yes, once you kind of get to understand that there's actually a biological change to the brain where someone can make some of those decisions. We've had here at Florida Recovery Center, we specialize in healthcare professionals, but we still treat people from all areas. We mainly treat doctors, nurses, pharmacists, judges, lawyers, but about the other half of the patients are just your mothers, fathers, daughters, and all come in with shame and guilt over some of the things they've done in active addiction. And invariably, as the dust settles, and even weeks into abstinence, for whatever reason, even under threat or involuntary, not have to be legal, but we know that nobody just shows up to treatment completely voluntary. There's usually some leverage that gets them there, and that's mainly because the brain has changed. The brain, as they say in some of the rooms, this is the only disease that tells you don't have it. But even quickly into their recovery, and you ask somebody once the dust settles if they would do some of the things now that they did in active addiction, and they don't even recognize that person, and they would say no. So you can start to see how the brain heals, because none of them are bad people. They're all good people with a bad disease that presents itself as bad behavior. And hopefully that can explain some of the poor decision making. Again, not an excuse, but an understanding. And once somebody understands that there's science behind it, and they know some of the reasons they're making these bad decisions, it reduces some of the guilt and shame over the decisions they made. Even with somebody with any other chronic illness that is having symptoms that are bothering them and they don't know what's going on, and they find out there's an actual cause for why they're feeling the way they are, there's a sense of relief. I've heard arguments that against the disease model that it doesn't reduce guilt and shame, and I've yet to find a patient where it hasn't reduced guilt and shame, which what it kind of drives them and keeps them in that addictive cycle. Once they kind of can kind of forgive themselves a little bit. Now they still have to make their amends to the ones they've harmed. They can kind of move on with and into recovery. Chuck, do you have anything to add to that?
No, I agree. I always go back to that it really aids with patient compliance. The patients then have an organ they've identified, a system that's working abnormally, and I think it increases patient compliance and helps with motivation.
Thank you.
So moving on to the next slide, just briefly, I know that I think, was it last year, y'all had experience with Admiral Murthy, who is a Surgeon General, and this is just to reinforce the top levels in medicine recognize this as a disease. I have other slides that talk about the top medical journals recognize it, the top medical societies recognize it, that anybody with any medical background now that weighs in on the subject sees it as a disease. The American Board of Medical Specialties that actually train every specialty and determine what kind of doctor you can be and the training you have to be that, meaning cardiothoracic surgeon, pediatrician, OBGYN, family practice. All those have to go through a certain training. Addiction medicine physicians have to do the same, and they're held to the same standard. Just a couple quotes there that you can read. Dr. Murthy, we have to help our country see that addiction is not a character flaw or a moral failing. It is a disease of the brain. And then Dr. Adams goes on to say, as physicians, we must say loudly for all to hear, we will not deny treatment to individuals with the brain disease of addiction. And I always debated if we were going to start seeing physicians really kind of buy in, for lack of a better word, because a lot are cynical against people with addiction. Every specialty deals with somebody with addiction, and usually that's the patient they don't want to see in the ER, and the ortho doesn't want to see the back pain patient, the ER doesn't want to see the overdose patient, the pregnant woman doesn't, the OB doesn't want to deal with a pregnant woman dealing with severe drugs, worrying about the fetus. But as I've started to interview fellows, so many are coming into this with no history of addiction themselves and really wanting to treat addiction. So we're getting through. I think we're at the precipice of making some big changes here, which is very encouraging. And as we even put in our book, and from Dr. Adams there, which goes along with the theme, stigma is definitely our biggest killer because it drives people from treatment. It keeps insurance companies from paying for it, and it keeps doctors from treating it. And it keeps families from helping. It pretty much impacts every aspect that somebody with any other disease people will be all in to help. And we need that same thing for addiction.
Thank you, Dr. Hunt. And as you move into that conversation around stigma, which we really will be expanding on in this conversation, it's so important as we think about the work that's occurring over the next couple of days. And we'll be talking about this in a few minutes as we move on, really the impact that stigma has on pregnant and parenting women. Thank you.
Okay. How are we doing on time? We got about a few more slides, and are we doing okay?
Yep, if you want to share those next couple of slides, and then we'll continue. We have a couple more minutes for a couple more slides, Dr. Hunt.
Well, the next slides are all on stigma. Do you want to do that after we've kind of gone through the talk? Do you want to just kind of separate from this and move on, or do you want me to go through these now? What do you think?
Anything that you want to share, we're certainly going to be falling back into some discussion on stigma and really talking about the work that's happening in Maine. Sarah will be sharing on that. So if you want to make a quick, any conversation on that, but we'll be reflecting back to that. Absolutely, Dr. Hunt.
Okay, well, we'll just power through these for you and then we'll keep going because, stigma is a huge deal. I mentioned it at the beginning. We've all heard sticks and stones may break bones, but however, language does matter. Stigma matters. Words matter. They determine how we understand and perceive our world. They carry power for good and for ill. And it's not a matter of political correctness. Until people with substance use disorder or addiction are seen as people, are seen as patients, and provided the exact same respect and dignity as everyone else, they're going to continue to die at alarming rates. We have to change the cultural perception of how we treat people and see people with addiction. And one of the easiest first changes we can make is through language. If you look at what's typically referred to for somebody with a substance use disorder or addiction is abuse, abuser, an addict. If you look at those words, they evoke more of a willful badness or a moral failing. They may even provoke punitive basis, compromising the quality of medical care. We don't use these words for any other condition in medicine or in healthcare. We typically save abuser for behaviors such as sexual assault, domestic violence, child abuse. And when you think about language with other diseases, we don't use abuser, we use patient, we use fighter, we use survivor, courageous, victim, endures. I talked about this in our pre-planning of how, I didn't recognize this either, but most people, you go back to the 1930s and 40s, you would have never put cancer into a obituary. It was not ever used. My mother died of cancer when I was young. It's kind of what motivated me to go to medical school. And I watched her struggle and fight every day for 5 years as a warrior with ovarian cancer before she passed when I was 20. But cancer back in the 1900s was considered a shameful disease, one that you brought on yourself because you had a weak moral fiber. So you would never mention cancer in an obituary. Like I said, they didn't even talk about people with cancer. They avoided them. They wouldn't touch them. What they call it? They would say, it's not the big C. It's not the big C. They wouldn't even say cancer. That seems ludicrous today. Absurd. People treated for cancer today are considered survivors, cancer survivors, and they post it on their car. That's how we know they're survivors. They talk about it. And that's what made the change. Look at breast cancer, for example. In the case of breast cancer, what happened? Well, they got better science, better research, better treatments, created support groups. Women spoke up. They talked about it. They got better. They survived. They became cancer survivors. That's what I want to see with this opioid crisis, which really isn't an opioid crisis. This is an addiction crisis. Every other substance has gone up too, with alcohol, benzos, you name it. So I want to see my addiction survivors out there. Next slide.
Wonderful. Well, and this is a great opportunity for us to move into some further conversation as well. If we'd like to continue on with the presentation to talk a bit about some of the work that's happening in Maine, Dr. Hunt, and blend this conversation in, I think that will blend really nicely. If that, we have about 18 minutes left. So if we move to that, would that be okay, Dr. Hunt?
For sure.
Wonderful. Okay, so if we want to go ahead and take the slides down, that would be wonderful. We know we have some more slides that really emphasize stigma, which we're going to be talking about. So, one of the quotes in the very beginning of the book, even before the forward, was from Jerome Adams, which you had just highlighted on your slide. And he said, "Stigma is our biggest killer." We recognize that diverse populations face an even greater rate of stigma. And one of the things that is so beautiful about the conference over the next couple of days is that you will be hearing the stories of recovery from pregnant and parenting women who were faced with that very fear that Dr. Hunt was just referencing, that were weighted down by the shame of their substance use disorder and wanted change, but there were immense barriers that may have really been put into place. The stories you'll hear over the next couple of days, they highlight recovery and really the determination and courage of these women. But we need to ensure that our systems, our words, as Dr. Hunt said, our messages, don't put it on the parents and the women to be courageous. Our systems need to be welcoming. They need to be compassionate. We need to have understanding and knowledge. We need to be open and welcoming and offering hope. There should be no fear for women, pregnant and parenting women, and families to seek treatment. So Dr. Smith and Dr. Hunt, you both have had extensive experience treating pregnant and parenting women impacted by substance use disorder. So would love to hear from you. Maybe we'll start with Dr. Smith. Any strategies that you've used to really reduce stigma in your practice as it pertains to this population?
Well, Jason, being an OBGYN, certainly has much more experience with pregnancy and addiction that I have. I have had some experience in dealing with patients and families, and mostly my focus is with families. I want them to give this patient support, just as they would with any other problems with pregnancies, or we actually talk about this in the book on the intervention, that we approach our loved ones the same as we would if we suspected a heart condition, if we expected a neurological condition, a stroke, a seizure, that we simply don't take no for an answer when it comes to getting them medical care. That's the intensity that I try to get across to families, is that they simply don't take no for an answer any more than you would with a loved one who you thought was having a heart attack. No, we're going now. We're going to do this.
Great, thank you. That compassion, warm, welcoming, understanding, bringing people in. Thank you, Dr. Smith. And Dr. Hunt.
Well, for the woman of reproductive age, parenting woman, pregnant woman, especially a pregnant woman, they endure a different kind of stigma. I mean, what they really endure is more of a prejudice or a discrimination, even laws against it. That really public policy or federal policy dictates that they should be the number one priority or top priority in treatment, and that's not the case. A lot of places, these women aren't offered treatment. The facilities are too scared to treat these women, and then you also have kind of the criminal justice system and the welfare system that kind of gets involved. So these women are scared, and the key is to continue to support them, offer them treatment, because a woman who's pregnant may see a physician or a healthcare worker 10 times, and 9 of them may treat her very, very well, very compassionate. But the one that doesn't, that's who they're going to remember, and that's going to keep them from going back. And we understand that a pregnant woman with any addiction, whichever one it is, from opiates to cocaine to opioids to benzodiazepines, with treatment, they deliver a baby that's just as healthy as a woman who doesn't have a substance use disorder. So co-located treatment, and the more treatment they get, the more they'll continue to receive the treatment, and also get all those other benefits that they can receive. So it's really goes back to stigma, and really kind of treating these women just like any other pregnant woman.
Yeah, thank you for sharing
Because
that.
like I said, go ahead. Because every woman pregnant really does want to, and they care about their health and the health of the baby to be. And those women that can't quit have a brain disorder, a brain disease, or an addiction that really just with a little bit of treatment can correct yourself pretty quick.
Thank
Go
you
ahead,
for
Abby, I'm
saying
sorry.
that. No, thank you for saying that. I think that's the conversation that I often share, is that the brain, whether it's a woman carrying a child or a male counterpart or a woman who's not carrying a child, is the same. And so the impact to the brain is the same. However, for decades, societal stigma has said it should be different because of that. So thank you for highlighting that. We're really also—
And the one thing can I say one more thing about that? You shouldn't have brought up this topic, but 50% of all pregnancies are not planned. 80% of pregnancies, just a woman who has a substance use disorder, are not planned. Doesn't mean unloved, unwanted. It just means not planned. At the time they got pregnant, they weren't planning to get pregnant. Doesn't mean bad moms. It just means not planned, not unloved. And I want to get that across.
Thank you, Dr. Hunt. And Sarah, we are just sure that folks are really wondering how we're doing in Maine to reduce stigma and to provide programs and resources for pregnant and parenting women and families living with substance use disorder. So would love to hear from you the work that's happening across the state.
Yeah, thank you, Abby. Happy to speak to that. And of course, we at the Department of Health and Human Services within state government, we're so committed to reducing stigma and providing these resources. And as you noted, Abby, just creating systems of care that are welcoming, that are co-occurring to support individuals and accessing the care that they need. I think first and foremost, I would highlight the expansion and extension of Maine Care health coverage for new mothers. Effective August 1st of this year, Maine extended our postpartum Medicaid coverage from 60 days after a mother gives birth to 12 months. And I was having a conversation with one of my colleagues, Dr. Belisle, and she made such a good point that the pregnancy itself is actually a protective factor. For women who are struggling with SUD, it's that 7 to 12 months postpartum that they are most vulnerable, which is why this expansion of coverage is so critical. I would also highlight our Maine Mom program. That program focuses on improving care for pregnant and postpartum Mainers with SUD along with their infants. Unfortunately, in 2017, Maine had the third highest rate for opioid-related diagnoses for mothers delivering in the hospital. So this Maine Mom program has been so urgent and important to implement, really based on a no wrong door approach, services that include screening, counseling, recovery coaching, and referrals to other services as well. But I think fundamentally, it's also a team-based approach and it's strengths-based. And we are very proud to have 19 healthcare sites across the state participating in that program. I would also note our Maine's plan of safe care. Folks might be aware that the United States federal government does require every state to design a plan of safe care for infants who are exposed and or affected by prenatal substance exposure. In Maine, a plan of safe care is developed for every infant who is born substance exposed. It creates a bit of a safety net to ensure the long-term well-being and long-term health outcomes for the infant, their mothers, and their family. I would also just note, you talked about the outset, Abby, just how much and important relationships are. And all of our work here in Maine is based on relationships and trust and is strengths-based. And our Maine's plan of safe care model has actually been a model for other states because of that strengths-based approach and because of the person-centered language that we use. We are also really focusing on our primary prevention efforts, particularly in schools. We have an opioid prevention and treatment fund, of which Governor Mills designated $1 million to go towards supporting proactive work with middle school students in their schools. The goal is to prevent substance use, teach resiliency, and foster that sense of mattering, which we know is a protective factor, particularly for youth. And we also are working very hard to expand our school-based health centers across the state, which also provide access to our youth to substance use and mental health services. I would also note under Dara's leadership, we are also advancing training here at the Department of Health and Human Services related to stigma, substance use disorder, and language. So this training will be available to all of our DHHS staff and will really focus on person first and non-stigmatizing language. So again, we're very proud of the work that we're doing here in Maine, and this conversation gives us ideas about how we can continue to advance that.
Wonderful. Thank you so very much, Sarah, for highlighting that amazing work that's happening across the state. And I just want to recognize that many of the individuals on tonight's call are likely part of that work, are doing this work in so many ways. So that's just wonderful to highlight. Also, for all of the participants, the links to all of the programs that Sarah just shared have been dropped in the chat box. So please go ahead and open those links up or save them for later. Just the work that's happening across the state, it's just been amazing to see over the last several years, the growth that's happened. So thank you so much for highlighting that. And it just ties so nicely into what Dr. Smith and Dr. Hunt have talked about around needing to advance this work and advance the conversation. And you mentioned building on relationships. And again, you highlighted the power of language. So before we move into question and answers, I want to tell you about a story about my friend Dina. So Dina, with her permission, I'm going to be talking a little bit about her. Like many of the stories that you'll hear throughout the next 2 days, Dina navigated a severe substance use disorder throughout her pregnancy and while parenting her 2 young daughters. Just like we've heard tonight, the stigma and shame associated with her substance use disorder kept her tied into her addiction. After entering the justice system, Dina met a team of caring and compassionate professionals and providers that wanting nothing more, like Dr. Smith said, to say, we're gonna do it now. We're here and we're here to help. It was absolutely not what she expected. Dina and I had the pleasure of facilitating a training called The Power of Language at a National Treatment Court conference in Nashville, Tennessee this year. While presented, we highlighted the power that words have and how these words, the words that we use, create labels and the impact that those labels have on individuals. As you can see in this picture, Dina is covered in the words that people had shared, the participants in the room, when we asked the question, what are some common beliefs about people with addiction? As people shared, we put those labels on Dina. I would like to share with the group, with Dina's permission, her comments and what she shared in reflection to that. Dina said, once the labels were on me, it was my turn to speak. Even though I knew these words were not me, I questioned whether or not anyone would even hear me based on those words. I felt these words were holding me down. It was always these labels that kept me in the dark and lonely places, afraid to show my eyes and not worthy enough to ask for help. These may have just been stickers that were on my body, but they felt like the heaviest chains. Stigma keeps me silent, unimportant, and too weak to participate in life. They make everything in life feel irrelevant, except for the substance that makes it all seem to disappear. Our words matter. Dina is now 13 years into her recovery journey. She is a certified addiction and recovery empowerment specialist, if you want to go to the next slide, if we're able to, which just really resonates that she's an empowerment specialist, right? Like, how beautiful is that? She works in the family treatment court in Douglas County, Georgia, supporting families just like herself that are finding recovery as they're navigating the justice system. So thank you to Dina for allowing me to share her story and really for us to see that visual of the unintended consequences of the words that we use. So while this was simply an activity, the power of words, we recognize the impact that it can have on community members feeling safe to enter services or feeling fear that may keep them continuing in their substance use. We're now going to move into some question and answers. I'm just so thrilled, and thank you to Dr. Smith and Dr. Hunt and Sarah for just all that you've shared tonight. Certainly, this is a topic that we could spend hours and days and months talking about. So thank you for helping us get it in this little window of time. What we just really want to highlight, as you move into this conference over the next couple of days, we really encourage you to remain in a place of reflection and growth, really taking that opportunity to connect with others, even though we're at a virtual conference, and just always remembering that the greatest tool that we have is our presence and our compassion. So thank you for being part of tonight's event. We have some questions, and we received some questions for the audience that we look forward to answering over the next 30 minutes.
Abby, real quick, we have 1 minute on the two of the last slides, just number 8 real quick, because what Sarah said I think was so powerful, and I want to emphasize something.
Absolutely. Are we able to share?
So
I don't have the share screen ability, but if we have the ability to share Dr. Hunt's last.
I'm bringing it up just 1 second here.
Great, thank you so much.
So just to emphasize on what Sarah said, it was so powerful, and you said it when you talked about her, the language she used, and it probably people didn't think twice about when she was talking to infants born to mothers who had a substance use disorder. She said, exposed, infant or neonate, substance exposed, and because there's no such thing as an addicted baby. And we see that all over. If you go down one more slide, 2 more slides, actually, you will see up one, how the media portrays these women, referring to them as addicted babies. And we know that babies can't be born addicted. Addicted is a chronic disease, and they can be born exposed, or they can be born with withdrawal that's easily treatable. And expected in some circumstances. But when she was referring to them as exposed, it probably didn't have the effect if she would have said crack baby or addicted baby. That sparks a whole nother thought of what happened. And we also know that there's no such thing as a crack baby. That was a myth. We have tons of literature on that. Once they went back and looked at all those babies, the slide above this one is the one I'm on. You would see that those babies develop just as well as their peers born at the same time. So it really was all due to stigma, all due to the war on drugs that brought out the terminology of crack baby, addicted baby. And just one more to mention this, we're the only developed country in the world where more mothers are dying from maternal death. Which is hard to believe in this country, right? Overdose is the #1 cause of death in the woman of reproductive age or the pregnant woman. And that's all due to the opioid crisis. It's overtaken preeclampsia, postpartum hemorrhage, all the conditions we used to be scared of that killed the very rarely a mother having a child, which should be the most beautiful moment of their life. But addiction has replaced all those and is the #1 killer. So, and most of that's due to stigma, because these women are scared to get treatment because they're scared of punishment. And we know that punishment of a disease does not work. The last slide, or the second to last slide, is really just to kind of bring that the brain heals, treatment helps. These brains can all go back to normal. And that's what we like to see. We want to give that message that treatment works. Too much attention's paid to the devastation of the opioid crisis or any other addictive outcomes. But the truth is, most people get better. and treatment does work. And I know we talk about that in our book. And I'll let Dr. Smith, if he wants to say anything right before questions. I know we got a little more time, and we're looking forward to your questions as well.
No, I didn't have anything right now. I'm ready for questions.
All right.
Okay, thank you
Perfect.
for bringing that back around, Dr. Hunt. That was great. Thank you so very much.
We do have a question in the chat. This question is for Dr. Smith and Dr. Hunt. What would they recommend as priority activities to reduce stigma against pregnant people living with substance use disorder in order to increase access and engagement in prenatal and OB care?
Go ahead, Jason.
So, well, mainly is to treat these mothers like any other patient. You know, right now they're scared. I have no problem with, you know, state involvement. And I think that also, I have no problem with state involvement in physicians who need care. It provides a little bit of leverage and helps them kind of stay on the right track early when the diseased brain is taken over and it's so hard for them to comply. But just like I don't want, you know, people with addiction to suffer long criminal sentences or crimes or punishment, it'd be nice to see these women get help, offered help, and understand that they're going to get help. That's why they don't seek care. They're just why it's like why most don't seek care. Like, it's funny, our healthcare providers don't seek care. They're afraid they're going to lose their license. But the reality is, if they understood that, you know, they're probably going to get treatment, insurance is probably going to pay for a lot of it, and they might even get paid while they're here. And they're going to go back to their job, just like if they had a diabetes or cancer. That understanding needs to be made with these women. And the problem is, what gets sensationalized is women losing kids. You know, the media shows the woman passed out in the grocery aisle, overdosed in her car. That's the way we portray this. We don't portray it as these women are, you know, courageous and survivors. And once they get over, we don't showcase the people in recovery. At least the media doesn't. So it really goes back to treating it like a disease and getting them the help they need. That's just not available for most people. 1 out of 10 people who have this disease get treatment. That has to change. And that's we don't have adequate long-term care. And, you know, that's really what it's going to take.
I also just want to highlight, Dr. Hunt, that a couple of times throughout tonight's conversation, you've really referenced that training and understanding of physicians in the medical practice around substance use disorder, and also recognizing that there is pregnant parenting women, right? Like there is maybe there is additional stigma related to treating of that, even in the professional field. And you've really highlighted that can be a barrier to individuals receiving services because maybe fear of treating or of being able to treat in a certain way. And so really that recognition of training, I've heard resonate throughout tonight's conversation, training and understanding of physicians.
And not only that, you know, training and education to the nurses in the hospital, to the social workers that deal with this, because even I've done tons of conferences to all those populations in Florida and South Florida, and they don't understand the treatment, the gold standard for treatment, the treatment that's been proven over 60 to 80 years that reduces overdose deaths by 90%, creates a completely healthy baby. And a lot of people don't understand that methadone and buprenorphine are the treatment. It's like, you know, it's like withholding chemotherapy from somebody with cancer. We would never do that, but people will withhold these life-saving medications and treatment, and that's what they are. They're treatment, and the studies actually show that the brain heals while on these. It's the education needs to be done at all levels.
Yeah, great, and that's a
Even
great
the patients.
point.
Sometimes the patients are even have their own stigma about it. They don't want to do it. They don't want to be looked at as that because everybody shames them. If they wouldn't shame them for being on insulin if their gestational diabetes went through the roof. And you know, so when every outcome is improved with those drugs, every outcome, there's not one that's not. Every maternal and neonatal outcome is improved greatly by those medications, studied since 1960. There's no debate, there's no argument, and yet we'll still have people not support the woman on it, or the woman doesn't want to be on it. And that's simply due to not educated on the medication.
Thank you,
just
Dr.
finished. No, I just want to share a comment that we have in the Q&A. This attendee is sharing, unfortunately, many women do have their children taken away, even if they do seek treatment once they are doing well. And the hoops and red tape that they need to endure is ridiculous. So I just wanted to acknowledge that comment.
Thank you.
No, and valid point. That
Dara, any other questions from the audience?
Another comment and question. I'd love to see our child protective systems in Maine make changes to decrease stigma for families. Sarah, can you share training that is happening for caseworkers about substance use?
Yeah, thank you for that question. As I noted earlier, Dara is actually leading some work to focus on training related to stigma and person-first language that will be offered to all of our OCFS caseworkers. I will have to follow up with the team at OCFS just to get a better sense of what training is currently happening for their teams across the state. But I do know that they work very closely with our offices in terms of collaboration and care coordination. And we've also, we have several Medicaid waiver pilots that are underway right now that I would highlight that are really focused on supporting women struggling with substance use that are also involved potentially with the Department for Children and Families. So also would just highlight those as areas that we're really trying to advance systemically here in Maine.
Thank you, Sarah. We have another question for Dr. Hunt. Can you cite the study you referred to regarding the brain healing with MAT?
well, there's been actually, well, I can't share it. We had a recent advances. A peak is a study that was done by Dr. Volkoff, which is she's the head of NIDA. She's probably the most world-renowned researcher in addiction for many years. You know, one of her quotes recently is, "We've seen repeatedly in the history of medicine that science is the strongest ally, and the opioid epidemic will not be any different." We've made remarkable strides in our understanding. It's actually the article is actually in the New England Journal of Medicine from 2017. If you want to know the edition, it's 377. If you want to know the page numbers, it's 391 to 394. And it's a look into the brain of opioid users as they try to quit and as they're treated with Suboxone. We've had the studies that show that stress and the CRF and the endorphin and all those things that causes the damage, the brain damage, the dysregulation, the disruption in the brain during the intoxication and withdrawal phase of addiction is improved with methadone. And this has been done now with Suboxone because these medicines last 24 to 48 hours. They don't cause the rapid cycles of intoxication and withdrawal that cause the damage. The shorter acting and the withdrawal phase is like a threat to the brain. The brain perceives it as a threat to its survival. So it's in fight or flight mode. It's like severe trauma. It's like if somebody hasn't been through that, there's no way to really describe it. It produces a craving that's unrelenting. Anybody hasn't been through that doesn't understand. And all that is a severe stress response to the brain that these people go through nonstop. So if you can think of that stress, that inflammation that's occurring, it's damaging these brain pathways and leading them to really just crave and seek the disease, the drug. So these medications stabilize that. They stop it almost immediately. It's absolutely amazing. I could have somebody in treatment because all the post-acute withdrawal effects, I mean, even weeks to months when they've got out of withdrawal and they weren't given this medication out of detox, they're irritable, they're easily annoyed, they're angry, they're depressed, they're anxiety ridden, they can't focus, they can't motivate, they can't even get out of bed, and people will blame them for that. And it's because the brain doesn't have the chemicals at enough level to get them out of bed. We have to have a dopamine level at a certain degree to even get out of bed, just like we have to have a heart rate at a certain degree to get out of bed, just like we have to have a respiratory rate of a certain to get out of bed. If I'm breathing 2 breaths a minute, I'm not going to do anything. If my heart rate is ridiculously low or ridiculously high, I'm not going to do anything. And that's the same thing with in addiction with the dopamine set point. every medical chronic system has a set point. Addiction's no different. So these people, their brains are so impaired for weeks to months to even years. Suboxone stabilize it. They become immediately engaged in treatment, and they don't have those that withdrawal, and it keeps them in treatment. There's been a study recently that showed that they gave everybody who left detox that went to treatment, half of them got Suboxone and half of them got a placebo and was told it was Suboxone. Once they did the study, 100% of the people with Suboxone finished their treatment, and 25% relapsed. When they looked at the people that didn't get Suboxone, 25% finished treatment, meaning 75 relapsed, didn't complete treatment, and 25% of them died. So 1 of every 4 died without it. So we know the medication works, and it's not for everybody, and it's not lifelong. So we know it works because it stabilizes the brain, it stops withdrawal, it stops craving, and it allows somebody to get the medical treatment they need. So that's really, and you can, I think I gave you all the references to that study. If there's any more questions on that, I'll be happy to field them.
The Q&A is quiet at the moment. I have a question that I'd love to put forth to both Dr. Hunt and Dr. Smith. How did writing this book change your lives?
Actually, for me, it was recovery that changed my life. Then the desire to want to share what I had learned in recovery. And as I said earlier, we saw early on when we would do education for peer support groups that this was well accepted by patients, well accepted by families, and that you could just tell it was starting to influence the stigma and the shame. People were actually comfortable saying they were in treatment, they were in recovery, and that their life was better. I use it mostly now with my patients. Before we had the book, I would usually have a half hour or 45-minute session of taking a patient through the dopamine reward system. Now, before we do it, I give them a book, and the next few days we go through that. I think patient education just greatly enhances patient compliance.
Thank you, Dr. Smith. Dr. Hunt, did you want to add to that?
Sure. I agree with Dr. Smith. The book, Recovery changed my life. We didn't really write the book for 10 years or so in recovery. And it was so easy to write because we really just spoke from the heart and looked at the things we had learned. And it was all stuff we believed, and it was all stuff that we researched and were facts. So it really just flowed. We really didn't, so I was really nervous about how people would perceive it because we really just threw it all out there. And I was amazed that most people do enjoy it. And like I said, it's kind of, just coming from the heart and coming from the passion we have in this field of medicine. So, took us a while to write it, and not Chuck's fault, but my fault. I always say that, his persistence got the book done, and my procrastination got the book done right. It came out at the right time. And just a real quick, brief comment on the MAT or the Suboxone or the methadone. That same effect and benefit goes to the pregnant woman, and that's why it improves everything in their outcome as well. But yeah, for the book's sake, I've been pleased and honored that you guys contacted us. That came out of the blue. We haven't done anything to really highlight it, promote it. We just wrote it and put it out there, and we give more away than we sell because and patients and families seem to really like it, and we just feel honored that so many people are getting something from it.
Thank you, Dr. Hunt. We do have another comment and question. Thank you for the information and insight being shared. Can you share any thoughts on addressing treatment for pregnant women who have a substance use disorder that is not opiate related, i.e. alcohol, cannabis, methamphetamine? Thank you.
The same treatment, and long-term treatment at that. And we're getting more of those treatments. Unfortunately, just recently, it's, really you're starting to have the resources to treat pregnant women. Like I mentioned before, there's just very few, and that just makes it very tough. This is a disease that really requires long-term treatment. And the sad reality is at the beginning, when the woman's pregnant, you know, they're kind of the center of attention. They're the center of focus. They've got visits every 2 weeks or every week if they're, you know, on a maintenance medication, and then the baby's born, and then everything goes to the baby, and the mother's just kind of left out there. Just if y'all had a baby, it's stressful. And now talk about having a baby and being in post-acute withdrawal without a medication. Now you're dealing with all the effects of withdrawal, and you're trying to raise a newborn. Very difficult. So a lot of support, a lot of social services, and then treatment centers that will take these women, because once they get in these environments and their brain starts to heal, they do very well. And pregnancy is a golden opportunity, a golden window to find this, because the problem most of the time, they don't want to leave the guy, and the guy's still using drugs, and it's very difficult. If you get them into treatment and into maybe even sober living, and kind of break that cycle, they do well. And when I talked about all women wanting to quit, the studies show that all cut back, but 80% go back to using after the baby's born, whatever their drug was, alcohol, methamphetamine. And you say, oh my God, that's horrible. My thought is, that's amazing. It's absolutely incredible. 20% stop. That's unheard of for the most part, with no treatment other than pregnancy. Pregnancy itself caused 20% to stop. You don't hear that with any other disease. So the deal is really more long-term treatment for these women.
I was very thrilled to hear Sarah say that they had extended the postpartum treatment through Medicaid to 12 months, because we highlight in our book that the prefrontal cortex actually doesn't completely heal till 2 years. Now, certainly at 1 year, it's much, much improved. But we're asking a new parent, and as Jason said, the living conditions may not be great. The significant other may still be using, so they're really taxed. So having the access to behavioral health people and addiction physicians is paramount in that first year, and certainly it would be nice if it could extend into year 2.
And that's the other thing that keeps these women engaged and reduces overdose. If they're on a maintenance medication, even after the baby's born, and like I said before, all that medical care attends to those weekly, monthly, those visits that the newborn's going through, all those well child checks, the mother's still seeing her doctor every month too. So that keeps the focus on her, and that can help them get through that really trying first year where, like I said, we have the highest maternal death rate per capita in the country, and the only one that's increasing, and it's all due to overdose in the postpartum period. 7 times greater at 4 months, or something like 11 at 9, 10, 11 months. So even at getting close to that year, they're very vulnerable. More women were dying at that end of that year than anywhere else. So that increasing treatment up to that 12-month is probably key, and probably driven by that statistic.
Thank you very much, Dr. Hunt. Well, the Q&A is quiet at the moment. We're at about 8:20. Abby, do you have any questions that you'd like to put forth?
Yeah, I do have a couple of questions. So the question that I have is, how important is it for someone who's living with substance use disorder to have an addictionologist on their medical team? You've talked about how that specialty is so important. So would love just to hear from you, just how important it is for someone with substance use disorder to have that player on their team.
Well, certainly, I think it's an asset. Certainly, some of y'all may be familiar with William White, an author who's written a lot about addiction, but I saw one of his comments early in recovery, how ridiculous he thought that someone could go to rehab and not even have a scheduled appointment with an addiction medicine physician over the next year. Obviously, a diabetic would have follow-up with their endocrinologist. The cardiologist is going to follow up with heart patients, et cetera. So I think it is essential for more rural areas that don't have addiction medicine physicians, at least a primary care physician who is well-versed in addiction medicine. We also see a big lapse in psychiatric care all across the country. And even the intake process is difficult. So what I always make sure when patients are leaving, that's one of the main things I look at in their aftercare. Do we have mental health services scheduled for them? Do we have behavioral health? Do we have cognitive behavioral therapy? All the aspects that we talk about in the book that really increase recovery from this disease, increase percentages of number of people recover. So I think it's very important.
Yeah, I agree. It's definitely not a negative. There's really no con to having an addictionologist on your team whatsoever, only pros. And for one, it's really growing. So a lot of places probably never heard of addictionologists. Like I said, it became ABMS recognized with the American Board of Medical Specialties in 2016. So it really became, even though it's been around through American Board of Addiction Medicine for a long time, it was just 2016 when it was really put up there with the big boys. Like I said, recognized as all the others, the same standard, the same treatment, the same training programs. When Chuck and I started fellowship a year before Chuck, but when we started, there was only like 11 fellowships in the country for addiction medicine, and University of Florida was the largest. We took 6, and the other 10 only took 1. So every year, as far as addictionologists being trained, you're looking at less than 20 coming out up until 2016. Now there's like 116 programs, and they won 187. So that's just in 5 to 7 years. So you can see what happened when it kind of became recognized as a legitimate medical specialty. Because unfortunately, with addiction medicine, most of us recognize addiction as from a addictionologist standpoint, that addiction is a disease, and we would like to see everybody else recognize it as a public or a legitimate medical disease versus a criminal problem. And we want it to be compassionately treated as a public health problem rather than a criminal justice problem. And most of us contribute that lack of knowledge or outdated moral views. But I've talked a lot about addiction and how it's similar to chronic diseases. But we do understand that it needs to be more education, because it is also different from most medical diseases and disorders because of its extreme consequences and externalities, meaning harm to others, which understandably make the public more fearful and angry about addiction than they would, say, asthma or type 2 diabetes or hypertension. I always make the joke that there'll never be a MADD. Y'all know what MAD is, right? There's never going to be a Mothers Against Diabetic Drivers. There's just going to be a little bit of a difference between addiction and the other chronic diseases, but there's also so many similarities that we have to recognize it as a disease. And relatedly, because violence and other crimes that may be associated with addiction, we have to acknowledge that the public's belief that law enforcement or the criminal justice system needs to play a role in addiction, and it has a rational basis, but it needs to not be overboard. We want treatment, not necessarily incarceration. And we're kind of lucky that the criminal justice system does play a role, because how many people get into treatment from a physician or a healthcare provider or PA or a therapist? About 3%. But about 80% get into treatment from a nudge from the judge. Now, as long as they, get treatment and go back to society if they haven't committed some violent crime, we don't need anybody going to prison for a minor, substance use issue, which has happened in the past. So, does that make sense?
Yeah, that was wonderfully said, Dr. Hunt. And really, it just makes me, as you share that, it makes me reflect on the amazing work that's happening across the state of Maine with all of these sectors that you've talked about and referenced, both in medical practice, but also within our justice sectors, and really around all of the sectors that I had noted earlier, workforce, behavioral health. Really, we're seeing a lot of advancement around wanting to learn, training opportunities, continuing to advance forward and reducing stigma, and really looking at best strategies to support community members impacted by substance use disorder. It is certainly clear just from our introductions tonight and just a recognition of some of the numbers that you shared, Dr. Hunt, that there's no one that goes untouched by substance use disorder across our communities, across the state of Maine, and across our country. And so we're all in this work together, which is just, I really am reflecting on that this evening. We did have one additional comment. I'll pull that from the chat before we go into closing, if that's okay, Dara.
Absolutely.
So there was shared, hello, I hear of people discharged from services if testing positive for targeted substances. Does this still happen? It seems more stigmatizing and less supportive of someone needed added support. And so as we're referencing that question, there was kind of a question and a comment in the state of Maine. I think that really falls back on substance use informed practices, all of those pieces that Dr. Hunt and Dr. Smith have talked about, recognizing substance use disorder as what it is, a disease, and really it needing treatment. And so really supporting that work and implementation of substance use informed practices, which would be treatment, not discharge, for the very symptoms that we would recognize that come with substance use disorder. So I'd like to see a number of advancements. As far
Yeah,
as the,
can I speak to that? Yeah, that happens. It never should happen. And actually, those people that you're discharging from treatment for using, have them look up the most recent lawsuit where $77 million was paid to somebody that kicked out for using treatment. I've never kicked anybody out of treatment personally. I've never kicked anybody out of my office or stopped practicing or treating them because I don't stop treating them for the same reason I started treating them. And that seems, and I always say that with, with the treatment center, I don't discharge somebody for the same reason I admitted them. Now, things may get a little tighter. They may have to see me more often. But I would much rather be held responsible for continuing to treat somebody that I still need a long way to go with other parts of their disorders versus abandonment, neglect, or discharge somebody from my practice for using, because I think that's I'd be more likely to be sued for that. I don't practice defensive medicine. And yeah, Chuck, if you want to answer to that, but that people that have been trained in addiction medicine through the specialties probably don't practice much of that CYA medicine. Somebody uses and violates their contract and they kick them out. I don't see that. I might tighten the reins, but it'd be like me kicking somebody out of treatment for diabetes because they kept coming with their blood sugar high because they kept going to Krispy Kreme when I told them not to. It's just not going to happen. But a lot do. So that's the change that needs to be made too. But if you look at ASAM, the American Society of Addiction Medicine, and the people high up making policies, they don't agree with that. Their training is, praise them for being off opiates if they're on Suboxone, and then deal with their continued use of meth or cocaine, or if they're continuing to drink heavily. Those things can be just separate. You don't have to stop treatment for one disease because their other diseases are still acting up. You just got to ramp up the treatment on those.
Yeah, I agree. Whenever I'm doing insurance company calls, for example, the insurance isn't wanting to cover an escalation in treatment or increase in level of care, I said, so basically you're just going to throw in the towel. This guy, if he had heart disease, he kept having angina and had 20 trips to the emergency room. I don't think that'd be your decision. That's really the way I would like our country, our society, our medical community to view it. We don't kick people out for exacerbations of disease.
Thank you very much for those answers. We're just at 8:30, but we have one question in the Q&A that Sarah would like to respond to. Sarah, go ahead.
Yeah, thank you, Dara. Someone had asked about how do I get involved? I want to have a voice in these conversations about our systems change. And I would say one thing I have learned, that systems change moves at the speed of trust. And we want to hear your voice and we want you at the table. So we have a couple opportunities I would outline. Our opioid strategic plan. We will be taking another look at that this year, and we'll be setting up some stakeholder sessions that will be coming up, listening sessions over the next month. Dara, I'm assuming we can get information out to folks related to when those listening sessions will be, because we do want your voice to be heard. We are also working on a strategic plan for our behavioral health system of care here in Maine. And again, we will have 2 stakeholder listening sessions coming up the end of October and early November. So we will make sure folks get that information.
Thank you so much, Sarah. Well, clearly we could continue this conversation, but I want to be respectful of the time. It's 8:31, and I know that people have already had a long day, and we really, really appreciate everyone joining us for this conversation tonight. I want to thank Dr. Hunt and Dr. Smith again for everything that you've brought to us this evening and for your magnificent little book. It really, it means a lot. Sarah, I'm so glad that you could join us as well. And thank you for sharing all the information about all the good work that's going on in Maine. And Abby, thank you so much for your wonderful facilitation and all of the insights that that you shared with us throughout the evening. So I wish everybody a good night. And if you are attending the conference tomorrow, we look forward to seeing you then. Good night, everyone.
Thank you.
All right, thank you so much.
Thank you. Good night.
Thank you.
Good night.